pregnant uterus.
20.
It's 12 onwards. Yeah. Yeah. Yes. And you can do your percussions on this one as well. You can do your percussions. So you can try it.
You don't mention it.
Yeah.
I can. Yeah.
Kindly step on the pedal.
Oh yeah, that's the
So you see that it has extended beyond the rib cage, so the border. So it's beyond the border. When you step, yes, because it's enlarged. But when you put the normal one in there and you even step on the pedal, it wouldn't fit. But you realize it aligns with the rib cage. Then we have a spleen and enlarged.
So when your colleague comes in the next day, you can say, well, we had 15 D lines present, and the next day it's 3. You say, okay, the diuresis is very successful. Okay, so now we're going to bring it to Africa here. There was an 18-year-old patient that came in. This is when we were in an EMT in South Sudan. 4 months of typical CHF symptoms: orthopnea, edema, dyspnea. We also have a low-grade fever. So that's not right with this. And why would an 18-year-old have heart failure? So normally we just give some Lasix. But we decided to do a blood ultrasound. And we saw this. Here's the diaphragm. There's the organ. There's one fibrinous tangle. Again, that doesn't mean it's a transudate. If there's more than one, or sorry, that doesn't mean it's an exudate. If there's more than one, it's probably going to be an exudate. So let's check on the other side. Okay, I don't see any of those fibrinous tangles in here. What's moving over here? That's the heart, okay? And there's this thick thing on the heart. So let's look at the heart here. What's going on here, Cindy? What do you see? He's a buddy cardiologist, right? What do you see? Yeah, pericardial effusion. Massively changing our management here. Would you give this patient furosemide? No. I saw their bright eyes and they're like, ah, you're right. This is tuberculosis. Okay? If you have tuberculosis, pericarditis. So, and at least in Juba, you needed this piece of paper proving it before they could qualify for the free drugs from the WHO. So that was really helpful to get that and get him on treatment. And after we did the pericardial infusion with it, or got it out of there, he was feeling much better. But we still have a lot of work to do, obviously. So now we look at the IVC. I know this might be kind of confusing, but so we followed up with another ultrasound and we saw this. So in this view of the heart, you see the left ventricle actually, squeezing pretty well, but the right ventricle is clear out here and ballooned out and pushing in on this wall here. So that indicates a high right pressure. We also see a lot of thick hyperechoic structure around the heart. So unfortunately, he probably has pulmonary hypertension with this big right heart and constricted pericarditis. So ideally, that would be treated with a pericardotomy, right?
And if you're disabled, you can be cared for. And in Medicaid aid support, if you're a pregnant woman or a young child, you'll get particular care. If you have kidney disease that has led to needing dialysis, you can get that care. But in the southern part of the United States, which is very interesting, as far as Medicaid is thought about, the issue is that many of them don't want to expand it to those who can't afford to pay for their health insurance. Our health insurance in our country is basically centered around employee-based health insurance. So your employer pays for most of it, and you put a little bit into the pot. But that's if you work 40 hours equivalent each week. What if you're at like a Walmart or some type of store where they only want you to work 38 hours a week. But you're like, no, I can work 45 if you let me, especially if you cover my health insurance, because I need to see a doctor here and there. And they tell you, no, that's okay, 38 hours, and for that, they do not have to pay your health insurance. So you do not have health insurance. But you're working overtime, maybe 50 hours to make more money, maybe you have a second job. But that insurance is not covered because technically, you've not been hired to work 40 hours per week. And so in southern parts of the United States and a couple of other areas, there are many people who are immigrant background, black, brown, poor, who do not have health insurance. And so in comparison, if you think about various models around the world, there's the Beveridge, the Bismarck, National Health Insurance, and to keep it brief, out-of-pocket, for instance, in Nigeria, there's a lot of out-of-pocket care. Even to, be transported by ambulance, you have to pay out-of-pocket. Working my way up from the National Health Insurance model, it's kind of like what you see in Canada, where the government runs the program and everyone pays into it. And then in Germany with the Bismarck model, there's no profit made per se, but the employer and employee, as well as the government, kind of covers everything. And then in the UK, the government funds it, the insurance, but there are long waits to get simple care, right? And then some of the more complicated care you might need, it can take even longer. And so, interestingly, in the US, if you're treating a veteran who served in the military, it's kind of like you're in the UK or Cuba, which is kind of cool. Okay, if you're over 65 and you have Medicare, it's kind of like you're in Canada. If you have insurance because you work a job and it's covering 40 hours per week, it's like you're in Germany. But if you're unemployed, younger than 65, older than 26, you may have a job, you may be an artist and work for yourself, it's like you're in Nigeria. You just gotta figure it out. You're gonna get that done. And then if you're under the Affordable Care Act and you're under the age of 26 and your parents actually have insurance, it's like you're in the UK. But this mixed bag is not healthy. And so compared to many other places, the US has the highest number of hospitalizations. And then concerning women, we are dying from cervical cancer, perinatal conditions, where you would think, okay, in rural areas of, say, Ghana, you're seeing these issues of maternal mortality. But actually, as an educated black woman who has, I don't know how many degrees at this point in my life, MD, MBA, BS. So like, I am at a very high risk compared to that of a white female who only has a high school diploma to die in and around childbirth. And I have a job. I work at a hospital. And I still am at higher risk. And you might say, that's insane. You can't be correct. I'll tell you why. And so life expectancy. The life expectancy in Iberville, New Orleans, near the French Quarter, where they have Mardi Gras. Have you heard of Mardi Gras? Okay. So right where they have Mardi Gras, the average life expectancy is 55 years of age. That's insane. And then further up is 80. Where I live in Atlanta, down where it says the Olympic Park, 74 years of age, that's near grade where I work. If you go to Buckhead, it's 84 years of age. Your life expectancy in the US can truly be determined by where you live. And so there's a resident, she's going into OB-GYN, and a med student, excuse me, and she's really excited. She's going into OB-GYN. She goes to visit this hospital, and the person says to her, "We have such advanced pathology here. Pathology like you see in Africa and Asia, the rural areas. It's just like that, but we have it in this city, in this hospital." And the resident thought it was pretty odd and slightly disgusting because her thoughts were, we are a high-income nation, and you're selling the idea of pathology as something exciting for people to learn when people are actually dying. And then on top of that, the issue is that these women who come in with cervical cancer, ovarian cancer, with Meg syndrome and sites throughout their gut, and pleural effusions and all these things to practice, they may look at those same patients and say, you haven't filled your potential, you didn't work hard enough, I worked pretty hard to get here. You're not really serious about your life or your future. I'll do my best to take care of you, but will I go out of my way? It's the same as you asked about white colleagues as well, right? So we have to ask these questions. If you know the history of it, maybe the treatment will be better. So there were laws in place that ensured unequal treatment in medicine, and we still deal with that framework. And that's called structural violence, because it's not something that you can see right in front of you. No one's hitting anyone, but if you set up structures within the government, within the school system, within how people are paid, then they won't have the access that they need to healthcare. And with this vicious cycle, you'll see inequitable outcomes if these rules are in place that over the course of 20 to 30 to 40 to 50 years, you'll find in the news that this group is violent. You'll see in the movies that this group is this way, right? When you see the immigrants cross the border from Mexico to Texas, there are thoughts that this group of people should just go back to their homes and just go home. But they can't go home because there's violence in their countries. And so we're not thinking about that when we see this on the news, and then it affects our opinion of them when they come to us. And poverty is a lasting national legacy.
Did you get a chance to scan? No? Okay. So again, watch how she holds it. We call this the scoop method. She'll just go down there and look around. Yeah, so she's up above the kidney now, and you see her hand goes down, and then the kidney comes there. Because it's a retroperitoneal organ. So I see a lot of people looking up here. Look at where the probe is. It's too high, okay? But you guys are doing something that's important, and that's, you're not looking at the floor. Actually, you're looking at the screen, and it's like a video game. You don't look at the joystick, but you just, yeah. You do, you're not very good. Yeah. So she just puts the probe on there, and then she, I call it, uses your, always looking at the screen. That's very good. Okay, let's rotate some more. I know it's very brief, but anybody that hasn't had a chance. And you notice you need to use plenty of gel. When we slide around, it gets dried out often. So don't be afraid to put enough gel on there. If you guys run out of gel, you can look on the internet. There's ways to make it yourself. You can use lotion also. So this works the best, but those other things work fine. If you don't have any gel, it doesn't couple very well. And ultrasound needs that connection right to the skin, otherwise the sound isn't transmitted. So you need plenty of gel. Maybe come up and lot of people, when they first start scanning the bladder, they I can't find it because they don't realize the bladder is really down in the pelvis. That's how it's rectum, you know. Usually a man this age would have this kind of prostate. I would think that's the. So he had bladder stones or sludge. Most of the time we do this to calculate the volume of the bladder. Okay? And that's just simply math, height, width, and then all you have to do, if it doesn't automatically measure it, then you get the height and the width here. I'll show you. So you do things like this. So it's almost like a cube, right? So we freeze, it usually shows the snowflake. And then just there and there. Oops. So 5.5, we just round it, okay? Because bladder volume doesn't have to be exact. The next one is about here, 6.7, okay? So let's just say 6 times 6 is 36. Then you get it in long axis here. See how I turned that? You feel that? Okay. This way, so you can go all the way. Okay, good. Now I'm going to freeze it and measure it. So 6 times 6 times, we're just estimating this one.
Right. Is it the same when you come to the left? Does it stay as it is? Superior is always left, and inferior is
Superior is where? Superior is here. Inferior is here. Anterior is here. Posterior is here.
no matter the side, the
No matter what.
once your full face is
Once the case is facing the patient is here.
So please, one at a time. You'll be here to guide you. One at a time.